Respected chairpersons, discussants, and the learned audience, I will be presenting one of the cases which we are used to manage in our daily practice. My patient is Mr. X, a 72 years male, who has an attack of myocardial infarction 3 years back, is seen in our hospital for worsening dyspnea with moderate amounts of housework over the past couple of the weeks. He has also noticed difficulties in falling asleep, so he has to sleep in his recliner chair. 2 weeks ago, his children were in vacation and were out of their home at that time. He ate out frequently at fast food restaurants. He has risk factors. He was hypertensive and dyslipidemic. He has no comorbid disorders, and he was having aspirin, Ramipril and atorvastatin for the last few years. At the time of presentation, he was dyspneic, tachypneic, hypoxemic, tachycardic, with a normal blood pressure, with no postural drop, and saturation was 93% as room oxygen. The extremities was well perfused, and there was 1+ bilateral ankle edema as well as presacral edema, and the jugular venous pressure is raised about 12 centimeter of water pressure. And the auscultation reveals a soft first heart sound, normal second heart sound, an S3 gallop, and a soft systolic murmur in the apex. The abdomen there was tender hepatomegaly. ECG shows sinus tachycardia and the Q wave in the anteroseptal leads. The complete blood count and the liver function test, thyroid function test, renal function test was unremarkable, except there was mild edema and there is moderate amount of hyperkalemia. So with this summary, possibly patient was having increased amount of fluid which produces hypervolemia. At the same time, there may be ingestion of salt-rich foods in the restaurant which may make congested for the patients. So with this summary, what could be the diagnosis, most probable diagnosis of the patient? Is anybody here to comment, MD students? Very simple and very clean-cut case.
It may be a case of acute left ventricular failure with old MI anteroseptal, with diabetes and hypertension, and the patient has previously diagnosed with CKD.
Oh, excellent. We are coming. Next question is, what is the best diagnostic step for rule out or rule in, and what is the best next step in the therapy, and what are the next options in the therapy after that, and how will address the problem of the anemia and hyperkalemia. So what the doctor was saying, probably he's a student, the most likely diagnosis is acute heart failure, and the patient has got an anteroseptal MI, he was hypertensive and dyslipidemic, as well as he has other problems of anemia and hyperkalemia. So according to the ESA definition, there are 4 defined clinical presentation of acute heart failure, and our patient belongs to acute decompensated heart failure, what he was telling about. Next, what is the best diagnostic step for rule in or rule out of the acute heart failure? Any students? Excellent. Because there is for diagnosis, for rule out possibly, and at the same time for rule in, there is single diagnostic test is NT-proBNP. But problem is that it is not available in every corner of our country. So that can be sometimes substituted by echocardiography in the context of our country. Which one is available, that can be done. But for acute heart failure, it is the NT-proBNP or BNP, which has to be done to rule out the diagnosis of acute heart failure in a patient presenting with acute dyspnea. So this is the guideline telling about like that. This is the guideline for chronic heart failure. And where there is diagnostic uncertainty after doing the NT-proBNP, then echocardiogram may help. Or where echocardiogram is doubtful, then NT-proBNP can help. One can be supplement another one. So both are essential in the context of availability of the test. So our patient has got very high rise of NT-proBNP, as well as echocardiogram shows wall motion abnormalities, ejection fraction 36%, and the GLS was 12.5% with mild degree of mitral regurgitation. So our echocardiography reveals his ejection fraction was less than 40%, so our patient was fit into the criteria of heart failure with reduced ejection fraction. But what should be the next therapeutic strategy to produce symptomatic relief to the patient, to give relief to the patient? Diuretics, fantastic. So diuretics should be the first step to relieve the problem of the congestion and hypervolemia, no doubt in it. And which should be the choice of the drug? Definitely better to prescribe the drug in the intravenous form, either loop diuretics or non-loop diuretics. If it is loop diuretics, then either it is furosemide or torsemide or bumetanide. And if you give the furosemide, either it is continuous intravenous controlled infusion or bolus intermittent, either 2 or 3 times in a day or once a day. So what the evidences say, this is the journal which has been, this is the topics or findings of a research work, Transform HF, in JAMA 2023. It shows that the torsemide and the furosemide has got no difference in terms of mortality benefit, in terms of repeat hospitalization. So furosemide is a drug which is very much available as well as is very much cheaper. So loop diuretics, furosemide is the best choice for relief of the acute hypervolemia as well as congestion because it produces rapid, prompt and transient diuresis. So how it can be prescribed? Is it very high dose or low dose or continuous infusion intravenous or a bolus? The studies shows, the dose trial shows there is no significant difference in terms of mortality, in terms of repeat hospitalization, both in low versus high dose as well as continuous infusion versus intermittent bolus infusion. But to me, in my practice, which I see that the continuous intravenous infusion produces rapid diuresis, rapid symptomatic relief, but it's your choice. So once you start your intravenous diuresis, you will give the patient the double the dose which he was getting previously in oral form. If it does not respond, you will increment the dose, and the maximum dose of the furosemide per day is 400 milligram. Either you give it continuous intravenous or intravenous. Bolus infusion. So if there is no response, then you can add thiazide group of the diuretics, notably metolazone, which is a single company, very rare drug, get it very rarely. So we have to remember that metolazone is a preferred choice. If it does not respond or there is less diuresis, less sodium output, less natriuresis, then you have to block the nephrons sequentially. Then after the diuretics, what should be the next step? Could it be switch to ARNI, MRA, or heart failure beta blocker, or SGL2 inhibitor? Which we continues the ACEI, we have added the carvedilol, we have giving the potassium lowering therapy, and at the same time decided not to start MRA. And you see, once there is euvolemia has been achieved, the next choice is to start heart failure beta blockers, carvedilol or bisoprolol or nebivolol or even metoprolol succinate. So next, whether we should start the MRA or not, our patient has got hyperkalemia moderate. So we have not started the MRA at the moment. And rather, we have started potassium lowering therapy by giving potassium binder or potassium chelating agent. At the same time, the furosemide will act to produce some extent reduction in the potassium level.
Soft
so
reminder,
next, we have
30
reviewed the diet.
seconds, sir.
And next, we convert the IV furosemide into oral furosemide and added the SGL2 inhibitors. And when the patient admitted, it is better not to start all the anti-failure medication at the time. You see in this picture, the picture depicted that we have to start one by one. First, we have to relieve the congestion. Second, at the same time, we can start the ACE inhibitor or ARNI or ARB, which one is compatible with the patient with no contraindication. Then once the congestion is relieved, we can add beta blocker, SGL2 inhibitor, and at the time of the discharge or just before discharge, MRA, provided there is no contraindication. So patient is anemic, so best way to treat the anemia in this patient is intravenous ferric carboxymaltase infusion. And this iron deficiency may present even in a patient with 12 or 13 gram of hemoglobin level. So without anemia, a patient may have iron deficiency. And iron deficiency may produce effort intolerance, more symptomatic problem. So once you infuse the iron and elevate the iron level, the patient will have reduction in the heart failure symptoms. There will be improvement in the exercise capacity. So patient is discharged with the ramipril, carvedilol, furosemide, aspirin, atorvastatin, and AMPA. 2 months later, patient developed left bundle branch block, but the ejection fraction was not so much improved. So we have shifted from ramipril to ARNI with a washout period of 36 hours and with spironolactone because the potassium level has been come down to normal. So these are the heart failure medication which has already been started and which we see at the end of the 2 years, patient came to us, his symptom was NYHA class 1, he has LV ejection fraction 55%, LVIDD 55, GLS 60. So what I will do? Will you withdraw all the medications gradually, or you will re-educate your patient, or replace the ACI in ARNI, or refer the patient for a second opinion. But we are more frustrated that in our expert, there is no consciousness about this withdrawal of the medication, even with a stable heart failure patient. So there is no clean-cut recommendation in any guidelines. But let us look at the evidences. This is the study, it's a trade heart failure study, which has been published in the Lancet 2019, which shows about 40% of the patient with dilated cardiomyopathy in a stable heart failure situation, when there is withdrawal of the medication, as high as 40% of the patient develop relapse or reappearance of all these symptoms. That is, all the patient developed again heart failure, pulse rate increases, LVF reduced, LV dimension increases, and there is increment of the anti-proBNP. So except a few situations like hemodynamic compromise, cardiogenic shock, or substantial renal dysfunction or hyperkalemia, there is no scope for withdrawal of the therapy. So the answer of the question is no. At this time, there is no scope for withdrawal of the medication. So considering these socio-economic barriers, which pose a major barrier and threat of using ARNI, SGL2 inhibitors in our population, in these cases, financially feasible options should be sought out in the context of Bangladesh. So thank you everybody, thank you for your patient hearing as well as active participation.